The purpose of this talk is to discuss the laws related to childhood asthma prevention. To discuss the scope of the problem, there are approximately 15 million outpatient visits for asthma exacerbations, 2 million emergency room visits, and 500,000 hospitalizations each year. 60% of children who have asthma missed a day at school. One-third required a urgent care or emergency department visit on an annual basis. There were 38 asthma-related deaths in school from the period of 2003 to 2014. 60% of asthma deaths were from a sudden asthma attack. This defines the scope of the problem for asthma and its management. The context of this brief is to discuss the law related to school-going children, the management of this disease, and the burdens associated with it are a shared responsibility of the schools, the parents, and the healthcare system as such, with the collective responsibility of the teachers as well. We will discuss the current law and policies for school-based interventions and programs. First, we should define the operational definitions of school medication policies, which must include authorization from the parents, authorization from the child's physician, a written treatment plan for asthma exacerbations and flare-ups, and a child's ability to demonstrate self-asthma management skills. Also, it is important that there is liability protection for the school and its personnel. In 2004, there was an Asthmatic School Children's Treatment and Health Management Act, which was passed by the Congress and became law. The statutes of the law are listed over here. The authorization to self-administer medications for asthma exacerbation was a key component of this law. Another key component of the law was that the schools needed to have usage instructions, and the child needed to demonstrate skills for self-administration of medications. Also, the schools were required to have appropriate documentation from the provider or the physician who prescribed the medication, and also from the parents for that to be on the child's medical record in the school. The law also defined liability waivers for the schools themselves who were taking care of kids who had asthma as a diagnosis. The intent of the law was to reduce the patchwork and create uniformity for the management of asthma in school-going children, especially outside of the healthcare setting and the home setting when they were in the school. However, the state laws were left to interpretation, and the states could alter the law to a certain extent. Also, these laws were supposed to be for public schools, and the private and the charter schools were exempt from this, or the law did not address private and charter schools, which left a lot of ambiguity as far as the management and the guidelines were concerned. The state laws that were interpreted were using the verbiage such as may rather than shall, leaving the law open to interpretation and to changes at the local and the state level. Some of the barriers to the law itself and its implementation included the local control that was allowed in the law. The parental engagement was limited, and that was noted as one of the barriers to its accurate implementation and effectiveness, since the parental engagement was a subjective issue and has multi-dimensional problems, including a lot of social determinants and life course theory and stuff like that. And this was a very subjective assessment as far as parental engagement is concerned. The assessing students' readiness to self-carry the medication was another issue that was identified in the surveys that were done by the American Lung Association. The availability of backup medications was an issue as well, and the protection of liability and the penalties associated with it were other barriers that were associated with the implementation of this law. So, the recommendations to change the existing law is to create education and awareness of the current state laws. The children should have extra medications for each child to be held in the school. There should be an asthma action plan in the school medical file, and there should be a law regarding school nursing availability. Monitoring school absenteeism related to asthma and its exacerbations is important, and including private and charter schools in the law itself would be an important next step. This is the end of the presentation.